Welcome to DaVinci Academy's Chapter 4 unit of the abdomen, our Lecture 6 on the liver, gallbladder, pancreas, and the biliary tree. So the first organ we're going to discuss is the liver, which is a very large organ, and it is highly complicated, and it helps with hundreds of synthetic and detoxification functions such as the production of clotting factors, as well as the production of albumin. It also helps with detoxification of recently ingested toxins. The liver macroanatomy is based on 4 lobes: the left, right, caudate, and quadrate lobes, the portal venous system that drains the GI tract, the hepatic arteries that provide arterial blood supply to the liver, and the associated biliary tree that carries bile into the duodenum. It also contains a liver microanatomy, which defines the functional unit of the liver based on a 3-zone histology referencing the oxygen content in the liver in relationship to the central vein and the portal triad that we'll discuss in a little bit. So the liver is one of the largest accessory organs in the abdominal cavity and is located in the right upper quadrant. However, there are certain situations it may actually present with the liver spanning the entire width of the abdomen and reaching the left upper quadrant. The liver lies immediately beneath the diaphragm and is located laterally to the stomach. It also comes into contact with the diaphragm and causing the top of the liver to be a very smooth area. And it's defined by what's called the ligaments or fascial attachments that we'll discuss in a little bit. So the liver is defined by the other adjacent abdominal organs, including the esophagus, the stomach, the duodenum, the gallbladder, the biliary tree, the right kidney, and the hepatic flexure of the large colon. The liver is an anteriorly located organ that sits beneath the anterior abdominal wall in the rib cage, as well as the esophagus, stomach, gallbladder, and duodenum that lie posterior and inferior to the liver. So now we're going to discuss the liver lobes. So the left and right hepatic lobes are the larger lobes of the liver, and it's divided by what is called the falciform ligament. The other 2 lobes, the quadrate and the caudate, are located on the medial surface of the liver. Functionally, however, the right and left lobes are actually separated by what is called the middle hepatic vein that drains into the IVC. So in discussion of the left lobe, it lies intimately with the stomach and the duodenum. The right lobe, which is considered to be the largest, actually lies intimately with the gallbladder, the portal vein, and the IVC. The smaller caudate lobe is actually located in the medial undersurface, superiorly between the IVC and the ligamentum venosum. Then you have the quadrate lobe, which is the one that is located in the medial inferior surface. So right here is where you have your quadrate, your caudate, right, and left. Now we're going to discuss the liver microanatomy. So liver is an encapsulated organ with 4 anatomical lobes and 3 hepatic zones. In these regions is where the synthesis of proteins and metabolites and the detoxification of substance actually occurs. Its 3 zones are based on how oxygen is kind of carried throughout the liver. So here's the portal triad. So this is where fresh blood is coming through. The zone 1 is where the highest oxygen content is, then zone 2, then zone 3. So as you can imagine, zone 1 has the most amount of oxygen content available, and zone 3 is where in times of ischemia or where there's less oxygen present, these hepatocytes are actually most risk to ischemic injury. It's then in the central veins right here that will actually drain into the hepatic veins that will then lead to the IVC. So it goes from the portal triad, blood flows to the central vein. However, it's from the central veins to the portal triad, in which this green arrow, as you can see, bile flows. So bile flows from 3 to 1, where blood flows from 1 to 3. So now we're going to discuss the liver ligaments. So the liver ligaments are these fascial attachments to the liver. The coronary ligament is located on the anterior and posterior peripheral surface of the liver next to the diaphragm itself. As you can know, the coronary comes from the meaning crown. So the coronary kind of sits atop of the liver, kind of like a crown. Then you have your triangular ligaments, which are the superior ligaments in contact with the diaphragm that are these triangular ligaments that kind of sit out on the periphery of the liver. You have the falciform ligament that kind of comes right through the liver itself. It's on the anterior surface of the abdominal wall of the liver. And it's important to note that it is actually a remnant of what we call the umbilical vein that used to actually carry oxygenated blood from the placenta of the mother to the fetus. Then you have what's the last one is the hepatoduodenal ligament. And this is actually one of the components of the lesser omentum, the other one being the hepatogastric ligament. And this is what houses the portal triad, which is composed of the portal vein, the proper hepatic artery, and the common bile duct. So as we mentioned, the blood supply of the liver is based on a dual blood supply. It gets very highly rich oxygenated blood from the hepatic proper artery off the celiac trunk, and it also gets much more deoxygenated blood, get nutrient and toxin-rich blood from the portal venous system. Then you have the venous drainage for the liver, which is very unique because it has 3 hepatic veins that directly drain into the IVC. The liver has a capsule, as discussed before, that receives a dense amount of innervation from the intercostal nerves surrounding the liver. During episodes of significant inflammation, injury, or even laceration, you can actually get very sharp, somatic, localized pain due to the fact that the capsule of the liver has somatic innervation from the intercostal nerves. But again, as the liver may become inflamed or injured, you can actually get referred pain in the right upper region of the shoulder. So now we're going to go ahead and discuss the gallbladder. So the gallbladder is another accessory abdominal organ that is hollow, and it's hollow in order to accumulate and concentrate the bile secreted from the liver. So the gallbladder concentrates the bile that is secreted from the liver, and then it houses it in the gallbladder so that when digestion occurs, it will secrete this concentrated bile into the cystic duct via the common bile duct and into the duodenum to help with degradation and emulsification of fats. In the cystic duct, which is right here, is where bile flows from the liver into the gallbladder, and then from the gallbladder back out into the duodenum. So the cystic duct is a short duct that enters the biliary tree and can often become obstructed by the presence of gallstones. And as we'll discuss later, it can either present as acute cholecystitis or symptomatic cholelithiasis. So the gallbladder actually contracts in the presence of what we call cholecystokinin, or CCK. CCK is released when food, fatty food in particular, descends through the stomach into the duodenum, releases signals initiating the release of CCK. So the gallbladder contracts, releases the bile, and the bile will then pass through into the duodenum. Anatomically, the gallbladder is divided into 3 regions: the fundus, the body, and the neck. Gallstones are a very common cause of gallbladder pathology. They can result from a host of different problems, whether it's from fat consumption and a fatty diet, or increased cholesterol consumption or production based on a fatty diet or just genetic factors, or whether it's decreased bile production, or even if there's decreased bile acid resorption, such as instances where there's ileal resection or Crohn's disease. So the blood supply to the gallbladder comes off of the celiac trunk via an artery called the cystic artery, which can either branch off the right hepatic artery or occasionally even the proper hepatic artery. So now we're going to go ahead and discuss the pancreas. So the pancreas is a very unique organ. It's a very sensitive organ. It does not like to be tampered with, and it does not like much manipulation. It's an accessory glandular abdominal organ that functions in digestion and homeostatic balancing of very specific hormones. It's unique because it's one of the organs that shares both endocrine and exocrine function. So the way that I remember exocrine functions versus endocrine is exocrine has these tubes. So anything that involves tubes is exocrine. And then the other way is endocrine just involves direct administration into the blood itself. The pancreas is located behind the stomach and travels into the left upper quadrant, almost touching the hilum of the spleen by its tail. The head and the uncinate process of the pancreas is in very close proximity to the second segment of the duodenum. So it's very important to note that the head, the uncinate process, and the body of the pancreas are retroperitoneal structures. However, the tail, which is very close to the spleen, is an intraperitoneal structure. So now we're going to discuss the endocrine function of the pancreas. So the pancreas secretes pancreatic enzymes that aid in the degradation of food and also helps with nutrient absorption. It produces bicarbonate and secretes it into the blood to help with the neutralization of the acidity that is secreted from the stomach. It also produces digestive hormones including insulin, glucagon, lipase, and somatostatin that help with the degradation of carbs, proteins, and other fatty byproducts in your food. So the exocrine, or like I mentioned before, the tube-like function of the pancreas is controlled by these areas in the pancreas called acini. So the acini will actually produce serous secretions that pass through the intercalated ducts, and then pass through the interlobular collecting ducts, and then pass through the collecting ducts into the main pancreatic duct, which then eventually empties out into the duodenum, passing through the ampullary levator, uniting with the common bile duct, passing through the sphincter muscle of Oddi, and controls the output. So now we're going to go ahead and discuss the anatomical components of the pancreas. So the pancreas is a very, very unique structure. It kind of has this really wavy, glandular, fatty, fibrous kind of like makeup. It's composed of what we call the uncinate process, the head, the neck, the body, and the tail. So the head is very close in proximity to the second segment of the duodenum and contains the union site of the common bile duct and the pancreatic duct. It also contains the accessory pancreatic duct as well. The neck is located between the tail and head of the pancreas and above the uncinate process. The lungeing process is located medial to the head, inferior to the neck and body of the pancreas, and superior to the third segment, which is right here, of the duodenum. The body, which is the central portion of the pancreas, is between the neck and the tail, which is right here near the spleen, is in the distal portion of the pancreas. It's an intraperitoneal structure, and it is also sometimes fixed in the splenorenal ligament. So the pancreas has, as I mentioned before, it has two ducts. It has the main pancreatic duct and also has the accessory pancreatic duct. And that's because both of these come from different embryological origins. The main pancreatic duct actually will drain into the duodenum via the major papilla. The accessory pancreatic duct will drain into the duodenum via the minor papilla that lies right above it. So now it's also very important that if we're going to talk about the pancreas and the endocrine exocrine functions, it's important to talk about these regions most numerously in the tail of the pancreas. And that's called the islets of Langerhans. The islets of Langerhans are these little islands of cells that contain alpha, beta, and delta cells. The alpha cells produce what's called glucagon. The beta cells produce insulin, and the delta cells produce somatostatin. And as you can see, in these little islets, it's the beta cells that are the ones that are most numerous. They're sporadically located. It's the delta cells that are also sporadically located, less numerous, and then it's the alpha cells that are more centrally located and are still less numerous than the betas. So the pancreas lies anterior to the aorta and the IVC. It lies anterior and medial to the spleen, as mentioned before. The tail of the pancreas can extend, as we mentioned, as far as the hilum of the spleen and is considered to be an intraperitoneal structure. It also lies posterior to the stomach. And the pancreas also lies medial to the duodenum, with the head of the pancreas resting above and on the second segment of the duodenum. So again, this is just recapping all the important anatomical relationships of the pancreas. So the pancreas actually gets two blood supplies, one from the celiac trunk and then one from the SMA. It gets branches off the splenic artery, which is a portion of the splenic trunk. It also gets blood supply from the superior pancreaticoduodenal artery, which is again off the celiac trunk, and then blood from the inferior pancreaticoduodenal artery, which is off the SMA. The venous drainage of the pancreas parallels these arteries and drains to the portal venous system and empties into the either splenic vein or the superior mesenteric vein and eventually into the portal venous system. So now we're going to go ahead and discuss the biliary tree. So the biliary tree is a very unique structure that extends from the liver, passes through the pancreas, and it goes into the duodenum. It's very important because this is what transports the bile that is produced from the hepatocytes in the liver. Bile helps emulsify fats and increase the absorption of these fatty and cholesterol-dense foods. Bile is unique because it's a substance that is composed of water, cholesterol, bile salts, phospholipids, and electrolytes, just to name a few. It's important to note that without bile, your stools will become very different in consistency and can even cause severe abdominal distress, it can cause recurrent diarrhea, and even steatorrhea, which is fatty-filled stools. So the course of the biliary tree is very important to memorize. It all starts in the liver at the bile caniculi, which drains the hepatocytes into the intrahepatic bile ducts, which then drain to the interlobular bile ducts and eventually into the right, as you can see, right and left hepatic ducts. Then it enters into the common hepatic duct, eventually merging with the cystic duct, and again union with the common bile duct, and then eventually further union with the pancreatic duct, and empties right here, not drawn to scale, into the duodenum at the ampular vater. So as we mentioned before, with the pancreas being a very sensitive structure, the biliary tree is also a very sensitive structure. And any sort of disruption in the proper function of the biliary tree can cause stasis and eventual obstruction, leading to jaundice and sclerolictris, just being a presentation of jaundice in the eyes. So the common bile duct empties into the second segment of the duodenum, as discussed before, at the union site of the pancreatic duct at the ampular vater, surrounded by the muscle of the sphincter of Oddi at the major duodenal papilla. This is a very dense paragraph, but this is something that's very important to kind of memorize. The biliary tree does not have somatic innervation, but does receive similar GI or visceral innervation. And during times of pathologic distension or obstruction, this visceral pain can be perceived similar to a lot of the surrounding GI organs. So now we're going to go ahead and discuss the clinical pearls for this unit. First, we're going to discuss symptomatic cholelithiasis, which means symptomatic or occasional stone in the gallbladder. And these gallstones arise for whatever reason, and it causes pain when CCK is released, causing contraction in the gallbladder like this, contracting upon the gallstone and causing pain. This is usually seen in postprandial or right after eating, right upper quadrant pain, and it's usually more intermittent. It's detected on the ultrasound, or if no gallstones are detected in ultrasound, you can do a thing called a HIDA scan, which secretes a radionucleotide into the bile. Bile will usually enter into the gallbladder, and you can see this light up like a Christmas light. If this does not light up at all, then that means there's some sort of obstruction here, and it's possibly a good sign to indicate that this is a gallstone obstruction. This is treated with elective laparoscopic cholecystectomy. For comparison now, acute cholecystitis is when you actually have the gallstone further down inside the cystic duct itself. This leads to increased pressure and compression of the gallbladder vessels running in the wall of the gallbladder. Since the arteries are high pressure systems and veins are low pressure systems, the arteries will continue to supply blood to the wall of the gallbladder, but this increased pressure will actually close off the veins, which will then cause blood to flow into the gallbladder and have nowhere to leave. This eventually compromises the gallbladder, leading to ischemia, necrosis, and eventual infection. This can also present with postprandial right upper quadrant pain and a specific sign called Murphy sign. So Murphy sign is when you take your hands and you palpate the right upper quadrant pain, you tell your patient to breathe normally. And as they breathe normally, an inspiration, and you press down the right upper quadrant, the pain is so significant as it irritates the diaphragm, it actually causes the patient to actually stop breathing for a second. That is called a positive Murphy sign. You can also diagnose acute cholecystitis with an ultrasound, and you see that the ultrasound shows pericystic colic fluid. It shows a gallbladder wall thickening of greater than 4 millimeters, as well as a sonographic Murphy sign, in which you actually, instead of using your hands to push down on the right upper quadrant, you take the ultrasound probe and you actually push down. This is very, very different because we're talking about ischemia, necrosis, and perforation of the gallbladder, which can cause peritonitic signs and acute abdomen. These instances will actually require an emergency surgery, or most likely an emergent laparoscopic cholecystectomy. Now we're going to discuss choledochlythiasis. So this is when you have a stone that has now passed through the gallbladder, the cystic duct, entered into the biliary tree itself, and is now lodged somewhere in the common bile duct. This presents with what we call Charcot's triad, which is right upper quadrant pain, fever, jaundice. And then a lot of these other probably nondescript things like nausea, vomiting, so maybe some elevated liver enzymes, and probably some hepatic congestion. But most likely, you're going to be tested on it, and you probably will see it. Charcot's triad, right upper quadrant pain, fever, and jaundice. So how do you treat this? You just got to go in there and you got to take that stone out. MRCP is pretty much an ERCP using MRI, which is great diagnostically, but serves no therapeutic function. So you can use an ERCP to both diagnose and treat, which makes sense. It's just easier and kill two birds with one stone. So you can diagnose it and you can treat it. Acute cholangitis is pretty much the exact same thing as choledochlythiasis. But the difference now is these individuals are very, 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 very sick. These individuals have a gallstone present in the common bile duct that has caused significant biliary stasis. And what now is the common bile duct will actually dilate, predispose the common bile duct to an infection. The infection can actually ascend upwards into the liver, and these patients can become very, very sick and septic. These are the patients that when they come in, you know they're very sick. When you see them, you would know right away acute cholangitis kind of jumps to the top of your differential. So these patients appear very, very sick, very ill. They have what we call Reynolds pentad, which is composed of Charcot's triad, as well as hypotension or shock, as well as altered mental status or encephalopathy. So this one, you diagnose it again with LFTs, blood cultures because of possible infection, as mentioned before. You can also ultrasound the biliary tree to see the presence of dilation. And again, like I said before, ERCP, both to diagnose it and to treat it, because you got to get this stone out. You got to both treat them, you got to keep their blood pressure up, you got to get rid of this infection that's probably going to be there, and you got to pull that stone out. Also, it's important to note that before these people leave the hospital, both in choledochlythiasis and in acute cholangitis, you got to have an elective cholecystectomy before they leave the hospital, because this is what's causing the stones. This is just what's going on now. If you get rid of this and you fix this whole problem, you didn't fix the source. So you got to remove the gallbladder eventually. When ERCP doesn't work, you're at very significant risk of actually causing so much compression and backing up into the liver and causing more hepatic failure that sometimes you actually do a thing called PTC, where you stick a needle into the biliary tree to kind of decompress all the backing up, all the stasis and fluid that's kind of accumulating in the liver. There's a few other conditions we want to talk about too, especially when we talk about these accessory GI organs. One is pancreatic divisum. This is when you have a congenital condition in which the pancreas and the pancreatic ducts of the dorsal and ventral pancreatic buds fail to fuse together. So the dorsal and ventral components remain separated and enter the duodenum at independent ducts, as we discussed before. That's why we have the minor and major papilla. Realistically, this is most likely going to be asymptomatic, and it's just one of those things they like to test on in class, but it's going to be most likely an asymptomatic problem. If it does become symptomatic, the patients may have a little bit of nausea, vomiting, and increased risk for pancreatitis, but again, this is probably going to be one of those more asymptomatic kind of like stroke your chin kind of interesting things to talk about. The other one that's probably more important to note is what we call annular pancreas. This is a congenital anomaly where the ventral and dorsal buds fail to actually fuse correctly. Not that they don't fuse, they fail to fuse correctly. So if this is what we call a normal pancreas, as they fuse on this side, on the medial side of the duodenum, and this is what it looks like embryologically, what happens is the bud, say the ventral bud, is actually on this side. And what happens is, as the duodenum is like this, you have this portion of the pancreas and this portion of the pancreas. And what happens is they will actually fuse across the duodenum like this. And as you can see, it's almost forming this little ring around the duodenum. And what happens now is this will actually cause compression of the duodenum and actually occlude it as food tries to flow through. It will actually fuse around the second segment of the duodenum, and actually can present with things like significant low birth rate or polyhydramnios or even feeding difficulty because food has trouble passing through the duodenum now. The last thing we're going to talk about is pancreatitis. Pancreatitis is a very common presentation whether you're going into surgery or internal medicine. It's something that you probably will see and will see often. You either have acute pancreatitis, which is, as you can imagine, acute meaning pretty sudden, or chronic pancreatitis. Acute pancreatitis is where you get this acute, sharp epigastric pain right in the middle of your stomach, or almost substernal at times, that can even radiate to the back. And it's classically defined by no restful position. It is diagnosed by two of the three criteria, one being symptomatic epigastric pain, the second being elevated amylase or lipase that's 3 times the normal values, or some sort of radiographic findings. What's also important to know with acute pancreatitis is this thing called pseudocysts. These pseudocysts commonly occur to kind of wall off this leaky pancreas that kind of occurs, and what happens is it may increase in size to the point where interventional drainage is actually needed. And it's also scary to note because these pseudocysts can become necrotizing, it can also become infectious. People that have multiple bouts of acute pancreatitis, or they have several recurrent episodes or a significant exposure to alcohol or gallstones, may get what we call chronic pancreatitis. In these instances, the actual pancreatic enzyme levels may not even be increased, but what's happening is all this attack on the pancreas is going to actually cause the pancreas to get more and more tired, more and more affected, and actually potentially even lead to increased risk of malignant proliferation of pancreatic masses. And this is one of those great mnemonics that I found super helpful, especially when I was studying for my Step 1 boards and my examinations and even in the wards, was knowing the common causes of pancreatitis. I get smashed. And as you can see, it's idiopathic for I, gallstones, which is the most common. Second most common is alcohol. Attendings love to pimp you on these two right here. Any sort of steroids treatments, mumps can interestingly do it, an autoimmune disorder can do it. Scorpions love it. Students love this. Attendings hate it when you mention this one. This one might be the highest yield in terms of what causes pancreatitis. Is hypercalcemia and hypertriglyceridemia. These will actually sometimes get you brownie points, especially if you know this. ERCP can actually cause pancreatitis in up to almost 25% of situations. And then very specific drugs, almost the toxic ones, like the AIDS-defining drugs like this, or the seizure medications like valproic acid can also cause pancreatitis. And that concludes this unit on DaVinci Academy. Thank you.